mode. So,
Well, you know what? I'm not going to worry about it, and I'm going to keep going, and you can all see my notes. How's that?
can't see
Uh,
the notes, just the slide, so you're
just
good.
right now, as soon as I change it, you'll see the notes. Anyway, let's get started, folks. We don't need to worry about it. Welcome, 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 everyone. Thank you for joining us. It's sunny here for me, and I hope that you're all warm and safe, and hopefully the sun is shining for you as well. I'm really glad to be having this Research Spotlight webinar today. It helps me do things that are meaningful to me, like my work. We're really happy to have Emily and Laura here from the ABI KTE team to talk about the Prescribed Alternatives program that focused on harm reduction workers. But before we get into the webinar, I'd like to take a moment to thank you all for being with us today. And I'd like to take a moment to acknowledge the land that we're on. So in the spirit of truth, reconciliation, and respect, I want to acknowledge where I live. I live in Sugum-Kikam, Mi'kma'ki, and that is colonially known as Shelburne, Nova Scotia. And it is the ongoing territory of the Mi'kmaq. And I also like to take an opportunity to ground us in what brings us all here today, and that is and how it's connected to truth and reconciliation. Many of us who come to these webinars and who are part of the Substance Use Health Network are working in social services and health services and sectors whose goals are to address social harms, social and structural harms. And these harms are produced through our colonial history and its ongoing, enduring practices, institutions, and ways of thinking. And we know that Indigenous people and members of the African, Caribbean, and Black communities are disproportionately harmed and criminalized by drug policies that are rooted in racism and colonialism. And just want us to always remember that colonialism is part of our day-to-day lives. It's with us today, and give us an opportunity to commit again and again every day to working in ways that transform racist and colonial institutions and practices, and to work to repair harms, prevent future harms, and work towards a more inclusive and equitable future. So I'd like you to take a moment to reflect on that. And if you are, if you'd like, you can also put in the chat, you can introduce yourself and say where you're joining us from. So for those of you who are unfamiliar with the Substance Use Health Network, I'll take a moment to introduce myself and the Substance Use Health Network, SUN. My name is Rebecca Penn. And I've been managing, leading, directing, coordinating, facilitating the Substance Use Health Network since it started as the National Safer Supply Community of Practice. About a year ago, we changed our name for a number of reasons, one of which is the substance use, or the National Safer Supply Community of Practice was really started to help support the implementation of safer supply programs or prescribed alternative programs that were funded by the Substance Use and Addictions Program in 2020. Over a few years, that was really the main focus, was implementing those programs. But during that time, we learned many, many things, some of which we'll be talking about today. And how safer supply was really about a lot more than just a prescription. And it really was about the need for a continuum of substance use health care that expands both harm reduction as well as more traditional approaches, and hopefully moving beyond that as well to community-based models of care. So we evolved to become the Substance Use Health Network. And the focus of our work is capacity building and really trying to make sure that we do expand that access to that evidence-based continuum of care and also that we work towards advancing drug policy that's rooted in the rights and realities of people who use drugs. Our membership just this week surpassed 2,000 people. We have people from every province and territory in Canada, as well as people from outside of Canada. So to find out more about what we do, you can check out our website, and you can join the community. We're still very much a community of practice, that we want to emphasize the importance of the community part of that term. We really do try to make it into a community. And next, some quick housekeeping. So we are recording this event. We will be sharing it on our website tomorrow. It's also posted in our YouTube channel. There is English closed captioning that you are able to access by clicking on the button on your toolbar at the bottom. We're going to have the presentation, and that will be followed by a discussion. If you have questions for our presenters, please put them in the question and answer box. That lets us be able to find those questions easily. Sometimes they get lost in the chat and things like that. I'm going to do a quick poll after the presentation before we go into the discussion. Please fill out the poll for us. That gives us stats that really help us with planning and with funding. And also, I just want to give a shout out to Reclaim Collective. Over the past year, we haven't had funding for SUN, and the Reclaim Collective team have volunteered their time and their work to help support the community practice to continue. And Tanya is here from Reclaim today and is helping me moderate the chat and being a big support to me. So thank you. Tanya and Anjay from Reclaim also do our Thursday drop-in meetings. And Tanya, you'll put the link to Reclaim in the chat so that folks can go to the website and learn more about the important work that Reclaim does. And then I just want to give a shout out to what's happening to in terms of our webinar for March. We have Isabel, Caitlin, and Tara coming to present on the MySafe evaluation, the final evaluation report for MySafe. And MySafe was designed as a low barrier person-centered model of care, providing secure access to prescribed alternatives through biometric dispensing machines paired with wraparound support. In 2024, the funding was abruptly discontinued amid shifting political and regulatory pressures, and this closure left many participants navigating sudden transitions in care. So this evaluation that Isabel, Caitlin, and Tara will be sharing with you all really looks at how the program shaped autonomy, access to care, stability, and daily functioning, and what changed when the program ended. We'll be talking about critical questions around sustainability, policy responsibility, and ethics of implementing high-impact pilot programs without continuity safeguards. We'll talk about key findings, explore the human impacts of abrupt program closure, examine the policy and funding context that shaped the program's trajectory, and we'll talk about recommendations as well. Okay, enough of me. Let's pass it over to Emily and Laura. Thank you all very much. And again, apologies for my slide share fail, but there we go. Thank you all.
All right, just bear with us while we also do our screen share and likely also fail a little bit with it, because I've currently got you looking at the wrong screen. There we go. All right.
Hi, I'm Laura Cartwright, and I'm the program coordinator of the Knowledge Translation and Exchange Program through AVI Health and Community Services.
My name's Emily Clayton, and I'm a clinical nurse educator with the same team. And today we're here to talk to you about the workforce program, as well as a case study that we did in evaluation of the workforce program.
That's right. And first, we would like to acknowledge that AVI and Health and Community Services works with individuals and organizations across all of Turtle Island. And we humbly honor the life force of Indigenous peoples who have had their lands stolen and who continue to resist ongoing genocide. Addressing the cause of the drug poisoning crisis necessitates speaking to the continual effect of colonization and to making every effort to decolonize our healthcare practice.
The content discussed today in the enduring paradigm of harm reduction is increasingly influenced by the shared knowledge from people with lived and living experience of criminalized drug use. Inclusion of people with lived and living experience ensures harm reduction initiatives are contextually relevant and also respectful of the people served. ABI encourages equitable and ethical inclusion of people with lived and living experience in all levels of harm reduction, service provision, program development, and evaluation.
So with today's presentation, we'll be covering the workforce program, the background on the toxic drug crisis in BC. We'll move on to a history of KTE and prescribed alternatives at AVI. Then we'll be discussing the workforce program and the case study and outcome recommendations.
The unregulated drug supply is the leading cause of death in British Columbia. In 2016, the provincial health officer declared the toxic drug crisis a public health emergency as 997 British Columbians died that year alone. Since then, over 19,000 British Columbians have died by unregulated drug death. And we can see here on this graph from the BC Coroner Service that in 2025, 1,826 individuals died.
Yeah, and the key challenges in mitigating the wave of death and degradation from the toxic unregulated drug supply are the continual adulteration of said supply and the criminalization of those dependent on same. Prolonged sedation, blackouts, and amnesia complicate care. Veterinary tranquilizers such as xylazine causes necrotic skin ulcers, while this and others like medetomidine add to the devastating effect of prolonged sedation. It is vital the care providers consider that people they serve are vulnerable to predation and internalized trauma, and that they respond to within that context with compassion and patience. In the fall of 2020, the Canadian Institute for Substance Use Research, in conjunction with Solid and the Safer Initiative, conducted a study. The facilitators asked people who used illicit substances what they would require to be comfortable in accessing prescribed alternatives to the illicit supply. The result was the concept mapping study. These are the statements where participants said prescribed alternatives would be a viable alternative to the illicit supply if the service afforded me 1, the right dose and right drugs for me, 2, positive and welcoming spaces, 3, safer supply and other services that are accessible to me, and 4, I'm treated with respect. 5, I can easily get my safer supply, and a service that 6, helps me function and improves my quality of life as defined by me.
In this presentation, we'll use the term prescribed alternatives, or PA, and this is synonymous with safer supply. So prescribed alternatives clinics at AVI offer accessibility through low barrier clinics that offer welcoming environments that are less clinical in appearance than traditional healthcare offices. And additionally, there's outreach support offered to meet clients in the community. Wraparound care is offered through an interprofessional team, including nurses, prescribers, support workers, and systems navigators. Client-centered care planning and medication changes are informed by the concept mapping study cluster statement of right dose, right drugs for me, and contribute to the flexible medication model used at ABI. Flexibility is offered through the medication options that are available to clients, including fentanyl options like fentanyl patches, dissolvable fentanyl tablets, and injectable fentanyl, as well as traditional opioid agonist treatment, so OAT, including slow-release oral morphine, methadone, and others, and also tablet prescribed alternatives are available. So the evolution of the AVI prescribed alternatives program started with the Safer Victoria Clinic, which opened in 2020 as a clinic, and then grew further to the Regulated Access to Drugs program in Courtenay and Campbell River in 2022, and also the Enhanced Harm Reduction program in Nanaimo, also in 2022. All sites utilize the same prescribed alternatives protocols and are informed by the same guiding principles. AVI's ongoing engagement with existing prescribed alternatives participants and local harm reduction workers revealed service gaps for harm reduction workers who use unregulated substances. This prompted us to explore how prescribed alternative access could be improved for harm reduction workers who are often excluded from the services that they help deliver and who are at risk of unregulated drug poisoning, just as anybody is who uses unregulated substances. Although many harm reduction workers who use unregulated drugs meet prescribed alternatives eligibility, their proximity to prescribed alternatives prescribers presents ethical and professional challenges. Following consultation with the College of Physicians and Surgeons of BC, AVI established robust safeguards in order to ethically design the workforce program. These safeguards included the prescribers work off-site with nurse-mediated clinical intake and follow-up, that medications be largely provided in community pharmacies, that prescribed alternatives be provided mainly via daily witnessed ingestion, and that dual position reviews for complex clinical cases occur. In addition to these safeguards, staff of the AVI prescribed alternatives programs aren't eligible for workforce, and this is due to ethical concerns regarding receiving prescriptions from the program that one works for. So with these safeguards in place, the workforce program launched in the spring of 2024, and this is an extension of the Safer Victoria Clinic here in Victoria. The workforce program is the first of its kind, serving harm reduction workers who use unregulated drugs, demonstrating a unique intervention. This photo here demonstrates the clinic room where workforce participants come for their regular check-ins. And so this looks like following up with the systems navigator, as well as checking in with the nurse. And this room is adjacent to a drop-in program as well as an overdose prevention room. So it makes it a little service hub for individuals. So the pathway that participants follow when they're interested in the workforce program goes as follows. So the workforce care pathway starts when a prospective participant submits a self-referral form to the systems navigator. It's all through self-referral. And these forms are distributed to local harm reduction organizations in Victoria, BC, and this is where prospective participants find them. The systems navigator then connects with the individual to discuss their self-referral and psychosocial needs. For example, the systems navigators assisted participants with gaining access to things like primary care, with following up with tertiary care, and a variety of other participant-led goals. From there, the systems navigator engages with the workforce prescriber and nurse, and we all collaboratively review the self-referral and make a plan to best support. Intake order or triaging is informed by scoring self-referred individuals using an equity and acuity criteria scale. And so this equity criteria includes BIPOC identity, gender identity, and housing status. And the acuity criteria includes whether a prospective participant has experienced a recent overdose or a drug poisoning event, if they've had a recent hospitalization related to unregulated substance use, and if they're ready to engage with the program at that time. The workforce program offers medication formulations, including typical opioid agonist treatment or OAT, as well as fentanyl patches and dissolvable fentanyl tablets. Upon intake, the nurse conducts a mental health and substance use assessment and a pre-dose assessment prior to providing medications. After the participant receives their prescribed alternative medication, the nurse assesses them during a titration or a post-dose observation period, and this is during the time that they're titrating up to their maintenance dose or the dose that they're going to stick at. After finishing the titration period, The participant reaches their maintenance dose, like I mentioned, and they're typically referred out to the community pharmacy for their medication going forward. And this transition to the community pharmacy is a significant piece of the workforce puzzle, and it's an example of the wraparound care that the program offers. Because community pharmacies can often offer greater hours of operation compared to our clinic locations, this allows scheduling flexibility for witnessed doses of medications. This scheduling flexibility is paramount for workforce participants who have busy work and volunteer schedules. And this demonstrates more autonomous care delivery as participants can work with pharmacies to build medication delivery and dispensation schedules that best meet their unique needs. Additionally, the systems navigator connects the participant with external resources such as income, housing, and identification services, and advocacy for a variety of other participant-led needs. And all of these services facilitate a continuum of care as the team maintains referral pathways and connections with external services and organizations. Finally, follow-up looks like ongoing engagement with the systems navigator, as well as at least monthly check-ins with the prescriber. So we wanted to evaluate early outcomes of the new workforce cohort and learn more about what harm reduction workers experience as participants of the workforce program. Between March and April of 2025, we conducted surveys and interviews with both workforce participants and staff. We followed best practice and research according to the Canadian Tri-Council Policy Statement, Ethical Conduct for Research Involving Humans, to make sure that we collected and stored data in ethical and respectful ways. And we looked at the data to identify key themes using an open source program called TAGET. So out of the 10 workforce participants that we had at the time, we did interviews with 3 of them, we did surveys with 4 of them, and then we did 3 interviews with staff.
Through participant interviews, survey, and data retention, we found that within the workforce PA programs, there were 0 drug poisoning deaths. Participants reported a reduction in their use of unregulated drugs, and some participants even reported complete abstinence from unregulated drugs. Participants also noted greater stability in their employment, including better ability to focus on work duties. Participants also reported improvement in their mental health, including stress alleviation, increased ability to complete daily activities, better access to healthcare, more use of social supports, and improved family dynamic and parenting skills. These outcomes speak to the logic of the intervention. One cannot ignore its contribution to improving the life of the participant, and one cannot deny the outcomes improve the health of our communities and society as a whole.
So as we explored the interview and survey data, we found 3 key themes.
From a lived experience, all interviewed workforce participants brought extensive lived and living experience to their harm reduction roles, outreach, program management, and research. Some described that current or past drug use helped manage trauma, pain, or mental health symptoms, and even enhanced work performance, challenging the one-dimensional narratives of drug use. However, they were also candid about the harms they experienced from unpredictable, unregulated drug supply. To quote, "I was terrified all the time, and while I was working, I couldn't concentrate on anything. My primary focus was, how are we going to make it so I'm not in pain? And then trying to mitigate the withdrawal symptoms, it was a nightmare." Regarding stress to support, the program's wraparound support and non-judgmental care were seen as critical to supporting stabilization and improved quality of life for participants. To quote, "I was struggling so much with my pain medication, and my GP at the time was dismissive. The amount of stigma that I had to deal with was astronomical. And then finally, the support that the workforce program was offering, I didn't even know that existed. It was such a life-saving thing." And regarding building stability, a program staff member reflected on the primary goal of PA to support individuals in separating them from the unregulated supply. And indeed, several participants achieved that goal of abstinence within their first year of the workforce program.
So we know that treatment and prescribed alternatives are not mutually exclusive, and PA may actually serve as a helpful bridge to getting to treatment. From the perspective of one of our participants, they actually see prescribed alternatives as a form of treatment. And I'll quote them. How do you even get to like abstinence-based treatment programming without something like safe supply to bridge to that? It's like methadone. It's a public health intervention. I see prescribed safer supply as a form of treatment. It's people making a concerted effort to either reduce their drug use or make it more stabilized. You're taking it out of the closet essentially and saying that you need help managing.
Despite the prevailing narrative that people who use substances don't participate in vocational aspects of society, our outcomes show that given the option, people will choose to better their situation, and in fact, given options, people will choose a safer alternative to the toxic drug supply.
And I really can't overstate how much of a privilege it was to get to partake in these interviews with participants and hear about their experiences. It was a really special experience. We're grateful. So workforce outcomes are positive. However, delivering prescribed alternatives within a medical model of care limits the flexibility and the autonomy that AVI strives to offer. A staff member explained, and I'll quote them, "We are in a period of incongruence with what we need to do to help people take steps towards improved health and recovery. Many of these programs are bound by paternalistic policies that require witness dosing and that directly contradict our intentions." End of quote. So for participants receiving twice daily dosing, this looks like 2 trips to the pharmacy every day. This is a huge barrier for one actually accessing their medications. Non-witnessed or take-home doses have been accessible to some participants after medication adherence was proven, and this has bolstered flexibility and autonomy, allowing them the agency to use their prescriptions at the times that they actually need it. However, in December of 2025, the BC Ministry of Health announced that all prescribed alternatives prescriptions must transition to witness dosing, creating significant barriers for those participants already receiving take-home doses, and barriers just in general. This hinders accessibility to one's meds and may result in one accessing the unregulated supply in order to meet their needs. This poses significant risk to one's safety, and it could result in death. The policy does highlight exceptional circumstances in which individuals who have already been receiving take-home doses may continue to do so if witness doses poses vocational barriers, such as witness doses conflicting with work or school schedules. It's hoped that workforce participants who meet this exceptional circumstance criteria are able to continue with take-home doses. The Workforce Program is the first of its kind, and innovations from the program include the adoption of a human rights approach to care, which challenges punitive abstinence-only models and prioritizes serving an underserved population. The Workforce Program integrates a continuum of care that bridges harm reduction approaches with addiction medicine. This integration is feasible as it may be incorporated into existing safer supply programs, and this can be life-saving for harm reduction workers.
So obviously this work has left us with some burning questions, and we continue to reflect on them ourselves, but we wanted to share them with you just to think over. How can healthcare and regulatory barriers that limit PA access be overcome? How can PA programs be scaled across healthcare settings and populations? And how can knowledge translation and practitioner mentorship be enhanced to expand PA access? How can knowledge translation improve understanding and counter mis or disinformation among providers, policymakers, and the public? And finally, what strategies increase stakeholder engagement despite political resistance? When asked what the most important implication of the workforce program was, a staff member explained, "A lot of barriers that workers experience in accessing harm reduction services are arbitrary and unnecessary. There's another way to support the workforce who are also dying from unregulated drugs that doesn't have to be regressive, punitive drug policy. I think that's the most important implication of the workforce program.
So thank you so much for listening to our presentation today. It means a lot to us, and we do ask that if you have the time, you might consider completing this 2-minute survey. It'll help us improve in what we're able to offer. There's a QR code here that you can scan with your phone. And if there's any issue with accessing that, you're welcome to reach out to the email on the screen, which is info@abi.org, and we can send you the survey in a different format. Or if you have questions in general, feel free to reach out. Thank you so much.
Thank you so much, Emily and Laura. That's, yeah, so much to talk about and think about there. I was really excited about this evaluation and this program in general, because how one of the roles that I started off at in terms of Safer Supply was coordinating the development of 2 programs into community health. 3, sorry, actually it was 4 harm reduction organizations in Toronto. And one of the big questions that came up there was, how do we get access to Safer Supply for our own harm reduction workers when there are these policies about not providing services to people who work for an organization? And there have been different ways that organizations have tried to navigate that tension, that ethical tension. And one of the ways that I have seen is by not actually employing people or like taking people in employment roles, but having them be like peer volunteers who are also like clients who are also doing volunteer work or whatever, but they maintain that client status so they can maintain the relationships there. And obviously that serves some people very, very well. And obviously it doesn't work at all for other people, particularly those who are looking to be employed in ways that are like more like mainstream employment. I don't know if that's the way to talk about it or not. But yeah, that's one of the things. So I was really excited to see how you were doing that. And yeah, it's great. Tanya, go ahead. You don't have to.
Oh no, okay, thank you. So refreshing this book. Thank you so much for the information. And for me, I really wish I had a program like this when I was struggling with use during, with working as a peer. I mean, we're hired partly because of our lived experience and because of these pieces. And when I was struggling and I really needed to reach out for help, it was very isolating, and I had to go to a different city, and thank goodness I drive to access OAT, because I was standing in line beside people I would be supporting, and privacy, there was no privacy, there was I couldn't tell work that I was struggling because of possible repercussions, or be them looking at me like maybe I couldn't do my job because I'm struggling with substance use. So this kind of program would have really helped while I was struggling at work. Yeah, so thank you for that.
Yeah, that's so good to hear and so relatable. It's still like the same struggle. We're not done.
Yeah, yes.
Sure.
Yeah, thank you for sharing.
That quote about the distractibility that people have when they're trying to do their jobs, but also like being afraid of of going into withdrawal or experiencing withdrawal, or not being able to secure, or being criminalized while trying to secure a substance that they need so that they can be able to perform in their day-to-day lives. That
And feeling
Before
like
this,
sorry,
go
go,
ahead.
sorry.
No,
Like,
please.
feeling like we're failing, like we can't, we're not able to, do our work because we're struggling. It was such a mind F for me. I was really confusing and really hard to navigate and really, really isolating. So, yeah.
Yeah, absolutely. There was a participant that shared that they had these challenges with focusing at work, and that they then struggled also with coming home from work and having to engage in parenting, being happy to engage in parenting, but struggling with maintaining sort of that happy and easy sort of demeanor when we're experiencing withdrawal symptoms at work, and then also when they're getting home from work. And so we see the impact of folks not having access to safer supply or prescribed alternatives, both in their vocational life and then in their personal life too. Yeah,
I've
it's a huge
seen
challenge.
too many peers just drop off.
Yeah.
You never, I haven't seen, if I can at least 10 peers in my 8 years, I've just not heard from because of the struggle that happens, and then afraid to say it to our employer, and they just sort of drop off, and it's really disheartening.
I think Workforce was definitely a program meant to mitigate those harms and it did its best to provide care for people that were employed and yet still came up against some restrictive policies. And, you see the difference in the past when people were able to maintain work-life balance a lot more, even when addicted to opioids. But since the drug poisoning crisis, the urgency has increased so much that basic functionality is just such a challenge. And it shouldn't be that way. And most people do want to stop or find an alternative because that was not the intention to be feeling like that.
Yeah. Yeah. And just again, like there's a number of things here, right? Which is just how much employment is such a stabilizing force, and yet how destabilizing is it to secure an employment position and then have to navigate that, as you said, like the distractibility, the fear, withdrawal, and all of that, performance, all of that sort of stuff. So not like, how do we set people up for success, and how do we set people up for failure, and where do our policies and it's always like it's like the term accountability, right? Accountability to whom, or whom, and all of that. Like, what's accountability for? Our finance departments may not be accountability for people who are working in places. And I guess it's the same I think about for this, like the ethics piece, like navigating those ethics around care. So messy, so complicated. And again, before we started the webinar, we were talking about unanswered questions and how, we have questions that we don't necessarily have the answers to. And there isn't necessarily a right or wrong answer. But it's important that we think about these things. Yeah. I really appreciated you bringing up the contradictions between the values and goals that AVI and the team each personally and professionally hold, and then trying to navigate, like, making those values come to life, but within a context with policies and that are like creating barriers all over the place. That tension is so real for so many organizations.
Absolutely. And even with the participants that aren't personally affected by the witness dosing mandate, for example, it's still terribly distressing. A lot of people voice that it's terribly distressing for them to even hear that these policies are coming about, and it induces a lot of anxiety, and it induces a lot of care and worry for the people around them.
For sure. Yeah, that moral distress that we've
Yeah.
heard about more over the past number of recent years than it feels like, like it's just really, really surfaced for people trying to.
I think we're also working towards transparent and honest conversations with folks so that they don't have to experience what Tanya was expressing, where they're suppressing their real life and their real struggles. It should be that they can go to their supports, their managers and supervisors to discuss the challenges they will have in maintaining their wellness. And, we're working very much toward creating the opportunities for those conversations to happen, because in the end, we are working under oppressive systems that counteract what we're trying to do in all our programming, and we have to keep within those parameters. But to mitigate the damage, it is the way that we communicate with our staff and our staff with our supervisors, so that we can build a culture of honesty and safety and acceptance rather than shame.
That's workplace wellness, right?
Yeah, there you go.
There's a comment in the chat. I'm not going to say your name properly, and that's
Devalia.
Devalia. If you want to speak, you're welcome to. We're a small group today, and so yeah, happy to let you speak. But Devalia says education sessions regarding safer supply options for clients living with HIV at AVI, accessing the lunch program would be beneficial to educate more individuals. Yeah. Okay. Let me give you permission. Sorry, yeah, allowed to talk. There you go. Just remember you're being recorded. That's all I'll say.
Hi, Devalia. Are you on mute? Devalia, we'd love to hear from you.
I'm going to move to Camille's, and if you can speak to Value, just let us know, and we'll give you some space to speak. Camille asks about Safer KTE and whether you offer support outside BC. Camille is in Quebec, and yeah, it works with a team that would really enjoy hearing from you. Oh,
yeah. We can't offer like that somebody become like a program participant if they're not in BC or not in Victoria, but we would be happy to connect with your organization to offer some consultation and share some resources about how we develop the program and the tools that we use. So I'd strongly recommend that you reach out to that info@avi.org email address, and we'd be happy to support however we can.
info@avi.org.
.org.
There, put it in the chat. Sorry, we can't hear.
And there is one Q&A from Heather
Great.
that says AVI has a ready to work policy, and I wonder if Laura and Emily could share a little about that as well. And then there's a piece that says the policy is complementary of the efforts of the workforce program to support HRWs, particularly when we see that prioritizing meaningful inclusion of people with living experience is seen as best practice in harm reduction, and especially in more mainstream settings where what it means to take a harm reduction approach is not fully understood or realized. Sorry, that was a mouthful. Laura, Emily, would you like to speak to that?
So Heather's asking that we share the ready to work policy, or share about how it relates.
Yeah, so share a little bit about that as well.
So AVI has a ready to work policy to help supervisors and managers mitigate challenges when their staff, any staff from entry to supervisory roles, have challenges performing their work, whether that be challenges from internal or interpersonal conflict, whether it's challenges around wellness, whether it's challenges around substance use issues or maintenance issues, and whether it's perhaps just overly, there's so many triggers and vicarious traumas that occur at this type of work. And then some people are overcome by emotion. So the managers are encouraged to approach people with compassion and understanding and care, and observe how those people are functioning. And if they're, for lack of a better word, behavior is counterintuitive to the work that needs to be done, then the supervisor may ask that staff member take a break. It could be just a fresh air break or nutrition break. Take some time to be supported in, having a meaningful conversation with their staff member, or maybe they would prefer to go home that day and come back the following shift. There's, of course, follow-up that goes into that, and work towards accommodation and accessibility to the job. So that policy helps to navigate through those difficult times and mitigate the harm. So it works to not stigmatize and not ostracize or isolate any particular staff. Does that answer your question, Heather?
Heather says, thank you, a great description. Demonstrates how supporting harm reduction workers can and should happen in a variety of ways. And yeah, absolutely. I love that you have that policy. It really demonstrates an organizational commitment and gives the supervisors, managers, and all staff a tool to navigate these situations that come up. They're not uncommon. So yeah.
Thank you.
We encourage you to go on our website, and under KT, there are many publications that describe the way that we mitigate harms and do this work. So please access through the AVI website.
Yeah.
Yeah.
Tony, can you throw that in? It's on I think it's in our Google Doc. But we have shared also the practice brief that you published in 2025.
Great.
That should also be really useful for people. That's also on our website as well. But yeah, the KTE team has produced a number of really important resources for organizations who are navigating, even if they're organizations that aren't necessarily prescribing safer supply or prescribed alternatives, so much of it is about, and again, this is what we were really learning when we were the National Safer Supply Community of Practice, that it wasn't really about the medication. Yes, that was one important piece, but it's about how people access that medication and what goes along with the medication, right? And that's a lot of what we see in the resources that you have produced. It's the how care is provided. Yeah.
Thank you.
Thank you and the team.
Yeah.
Been super. So what's next with the program? Are there any goals? Like one of the questions you raised, right, was how do we expand? How do we scale? And particularly in the current political context, and at a time when policies are constraining what and how care is being provided. You can do like the magic wand if you want and get rid of those constraints for a moment and tell us what your dream would look like, or you can stay in the here and now reality and say what ideas you might have. And I know we were talking before saying we don't have the answers, but just to get us thinking.
Yeah, for sure. I mean, I think a big part of the scaling up is the work that we're always doing, which is consulting with other organizations to help them with developing safer supply programming or prescribed alternatives programming, depending on where they're coming from. So that's a huge piece that we're always working on, and we're happy to support. So again, that email address is open, and we'd love to talk with anybody who has questions about that. Beyond that, there's so many existential questions we have, and we don't always know the answers, but I think something that would be great is if teams like our knowledge translation and exchange team could exist in other locations and sort of build up local or regional systems. But we recognize that, having both worked in frontline programs for a number of years, that kind of work is just not always possible when you're working frontline and you're so busy. That sort of engaging with other organizations and building referral pathways sometimes, or just sharing policies and procedures, it's just not always feasible. So I think if programs have interest in that kind of work, if they're magically able to wave a magic wand, like you said, and secure some type of funding to have some time to do that work, I think that would be huge for scale up too.
And also, like, mitigating crises should not be subject to punitive policy or cross-examination by politicians and or other detractors.
Yeah.
It is a natural response to a public health emergency. Safe supply has always been a appropriate response to a public health emergency, and it has been twisted over the political coals, and and further criminalized as though we are perpetuating the illicit drug crisis when we are actually the antithesis of that. It is extremely frustrating to be involved in sensitive and in innovative and intuitive programs and then see them dashed on the rocks so readily. Everything that we've done in to do with safe supply initiatives has been to help the public and is logical in its response. It mitigates the amount of people on the street. It even combats disease and crime because people have wraparound care that addresses so many of their needs. And we've seen through workforce, people don't want these illicit drugs in their system. They don't get euphoria from it. They don't get pleasure. They are tranquilized. Their bodies and minds are distorted, and they are very challenged in reintegrating into society. This is not like the days of heroin. This is very damaging poison drugs, and there is no room for people to. The risk is extremely high for overdose and for permanent damage and for cognitive issues and for musculoskeletal damage. And we have an answer, and we're being blocked at every turn, and that is the crime.
Yeah.
So well said, Laura. I'm really grateful for you articulating all of that. And it also makes me think about your question around how do we counter misinformation? I know when we started the National Safer Supply Community Practice, we were very much focused on supporting organizations and programs, right? So creating the policies, program design, that kind of thing, and bringing people together so they can co-create and making sure that people with lived experience were informing the creation of those policies and programs. And that was great. We had a very engaged membership and such, but it was interesting because over time, the demand on the community practice really shifted to things that were outside of our wheelhouse, which was public relations. And, communicating to the wider public, like how to bring the wider public on board. And we weren't prepared for that. And that really caught us off guard and started pulling in a lot more of our time and energy. But it was also too late. Like the train had left the station or whatever, right? And there were people much more like, what are they called? Like PR firms working for people opposed to safer supply that had, big resources. So yeah, how do we, or maybe, I don't know, maybe it's not a question of how do we, but just an acknowledgement that part of the work that we do now is in KTE is making sure that we talk to the general public as we include the general public as one of our audiences, as well as policymakers and such. That needing
I
to
think it's really important not to engage with detractors who bring inflated and scare tactics into the conversation, that we just continue. KTE's particularly focus is on evidence-based models and focuses on the evidence, and we just keep speaking the truth. Eventually it will prevail.
I think one of the things that really worried me a lot was, we do see the call for employing people with lived experience and recognizing the importance of work for stability and, being productive members of society, that whole narrative and everything, but then also not having, but at the same time as, trying to, as some funding policy, some funding pots have gone to like, let's increase the number of people with lived experience in those roles, but happening alongside the defunding of safer supply and things and those and harm reduction programs. So yeah, there's a real tension there. We are coming to the end of our time together today. Really, really grateful for the work that you do. We've shared some links for attendees in the chat. Those will also go on, all of those links will also be shared with this video recording on our website and on our YouTube channel. Any last thoughts or comments that you want to make before we say goodbye to everyone? Anyway.
No, I don't know if we have any other than just thank you so much for listening and for being interested in this. We're really honored to get to project the voices of our clients and our participants. So it's been a really great opportunity to do that.
Excellent. That's great. And I know you're doing those presentations more with some other audiences, so that's super to know as well. I hope you get some good feedback and engagement there. I look forward to the next AVI product resource. We love the work of your team and respect the team and AVI in general very, very much. Yeah. Thank you. And just the last shout out for our March webinar. Tanya, can you throw the registration link in? That one's going to be about the MySafe evaluation. So we've got two webinars back to back. That's about prescribed alternatives. There is a lot of research and evaluations coming out right now about programs. So yeah, we're trying to make sure we get that information out to people. And thank you all for joining us today. Stay well, take good care of each other. And thank you, Emily and Laura. Really glad to have you. And Tanya, big thanks to you for all your help today as well.
Yes, thanks, Tanya. Nice to meet you. Thank you, Rebecca.
Thank you.
Take care.
Bye, everyone.
Bye-bye.